Dear student, my name is Dr. Ahmed Al-Hamshari. I am otolaryngology head and neck surgery lecturer in Tanta University. Today we'll discuss the pharyngeal tumors. So anatomically, the pharynx is divided into nasopharynx, oropharynx, and hypopharynx. So the first part of the lecture will be about the nasopharyngeal tumors. So nasopharyngeal tumor is broadly divided into benign tumor and malignant tumor. And the benign tumors, the most common benign nasopharyngeal tumor is the nasopharyngeal angiofibroma. So nasopharyngeal angiofibroma occurs exclusively in males, and it occurs usually in adolescents, usually below the age of 18, and that's why we call it juvenile nasopharyngeal angiofibroma. At site of origin, this tumor usually arises from pterygopalatine fossa at the anterior aspect of the median or trigoid canal near the sphenopalatine foramen. And if you look at the top picture, you can see the anterior aspect of the median canal where this tumor arises. And if you look at the picture down, you could see the left sphenopalatine foramen, which has been expanded by the tumor growing medially inside the nasopharynx and the nose, and laterally in the pterygopalatine fossa. And compared to the right side, it is very widely expanded and eroded, while the right sphenopalatine foramen, the dimension of the foramen is very preserved. The pathology of the nasopharyngeal angiofibroma is broadly subdivided into gross pathology and microscopic pathology, and the gross pathology is associated with the discovery. It is a highly vascular tumor, and the tumor has a rubbery consistency, and normally this tumor is divided into two big parts which are connected together with a very constricted middle part, and it gives the appearance of a dumbbell shaped tumor, while the microscopic pathology will reveal that this tumor consists of numerous large vascular spaces separated by condensed connective tissue stroma, and these vascular spaces lacks the normal muscular coat, and that's why it easily bleeds, and the bleeding doesn't stop spontaneously, and this probably explains the recurrent severe attacks of bleeding from the nose. Behavior of this tumor: although this tumor is a histopathologically benign tumor, juvenile angiofibroma commonly erodes the surrounding bones. It spreads medially to the posterior nasal cavity and nasopharynx, laterally to the inferotemporal fossa, forward and laterally to the orbit, upwards to the intracranial cavity, and downwards to the oropharynx. The clinical pictures: this tumor normally present with a recurrent, severe, spontaneous unilateral epistaxis, and many of those patients present with nasal obstruction and discharge, which start at first unilateral when the tumor obstructs one side of the nose in the nasopharynx. When the tumor grows up and closes both sides of the nasopharynx, then the symptoms becomes bilateral. Oral symptoms include conductive hearing loss due to thickened tube obstruction. Signs of this tumor: endoscopic nasal examination will reveal smooth lobulated pinkish to whitish nasal mass which bleeds profusely on touch, while ear examination will reveal a retracted dull tympanic membrane due to otitis media effusion due to thickened tube obstruction. Oropharyngeal examination in large tumors only may protrude into the oropharynx. External examination will reveal extension of the tumor forward, which will cause broadening of the external nose and proptosis, which is called frog face deformity, or extension of the tumor laterally, causing swelling of the cheek and zygoma, which will augment the frog face deformity. Normally we investigate such a tumor with a CT scan and MRI scan with contrast, which will clearly show the extension of the tumor into the surrounding regions and spaces. Carotid MRI angiography normally confirms the diagnosis and shows the feeding vessel of the tumor and allow for a preoperative embolization of the feeding vessels. Biopsy usually not necessary to avoid severe bleeding. Treatment: the only method to treat such a tumor is to do a surgical excision of the tumor after embolization of the feeding vessel within 48 hours. Regarding the approaches, endoscopic transnasal approach is the ideal and the most commonly used approach in most cases, during which we do a very wide middle meatal antrostomy. So we do a very wide opening of the maxillary sinus orifice, and then we might resect the inferior turbinate and remove the whole median maxillary wall to get a full view of the posterior and lateral maxillary wall, and then we start removing the bone above the tumor in the posterior maxillary wall and lateral maxillary wall to get a full view of the tumor, and then we got the whole tumor removed through the nose endoscopically. External approaches includes transpalatal approach, lateral anatomy approach, and midfacial degloving approach. And midfacial degloving approach is the most commonly used one as an external approach, in which you do sublabial incision, and you do an incision through the membranous septum and on both lateral sides of the nose, and you get the soft tissue of the midface degloved from the anterior wall of the maxilla to get a full view of the anterior maxillary wall, which will be removed, and then by removing the anterior wall of the maxilla you get a clear view of the posterior and lateral maxillary wall, which will be removed as well to get the tumor out through through the midfacial degloving incision or through the sublabial incision. Nasopharyngeal carcinoma is the most common malignant nasopharyngeal tumor. It's commonly in male and commonly in elderly population. Site of origin of this tumor is a fossa molar, which is the lateral pharyngeal recess, which is this recess just behind the tubal elevation on both sides of the nasopharynx. You could clearly see the fossa molar highlighted as FR on the CT scan. It is the space just behind the tubal elevation, which will mark the posterior boundary for the eustachian tube orifice. The predisposing factor for such tumors are either genetic, environmental factors, and both of those factors contribute to the high incidence of this tumor in Southeast Asia, especially southern China, and Epstein-Barr virus infection, which is common in the Southeast Asia as well. And that's why these tumors probably have the highest incidence in Southeast Asia all over the world. Spread of this tumor is a direct spread forward to the nasal cavity, forward and laterally to the orbit, downward to the oropharynx, upward intracranially, and lateral to the eustachian tube and parapharyngeal space. Lymphatic spread early and common to the retropharyngeal lymph node, so there is the first lymph node station, and then to upper deep cervical lymph node. Distant metastasis in advanced cases to lung, bone, and brain. Clinical picture of this tumor is normally this tumor present with nasal obstruction and discharge, and it might present in a small number of cases with blood-stained nasal discharge or epistaxis. Oral symptoms are quite common presentation for this patient, so many of these patients present with a conductive hearing loss due to eustachian tube obstruction, and some of them might present with earache due to otitis media and invasion of the trigeminal nerve. For the signs associated with nasopharyngeal carcinoma, nasopharyngeal examination might reveal a fungating mass or malignant ulcer arising from fossa molar or lateral pharyngeal recess, as you could see in the picture in the top end of the presentation. And oropharyngeal examination might reveal immobilization of the soft palate due to invasion and paralysis of the soft palatal muscles. Ear examination might reveal unilateral otitis media with effusion due to eustachian tube obstruction. Ocular examination might reveal proptosis and ophthalmoplegia due to cranial nerve affection. Neurological examination might reveal paralysis of third, fourth, fifth, sixth, and the last four cranial nerves. Cervical examination, enlarged cervical lymph node might be the earliest presentation in those patients, and some of them might present either with bilateral neck metastases. Trotter's syndrome or Trotter's triad is a common syndrome or triad which contains ipsilateral conductive hearing loss, which happens due to otitis media with effusion with eustachian tube infiltration, ipsilateral soft palatal paralysis due to palatal muscle infiltration, and ipsilateral facial pain or trigeminal neuralgia due to perineural spread along the maxillary division of the trigeminal nerve. And these three types of finding happens almost always with each other because of the close proximity of the eustachian tube and the origins of the levator palati muscles and tensor palati muscles, and with the foramen ovale, which includes the trigeminal nerve. So with the tumor starting in this place, it will affect these three different structures, causing these three frequent frequently associated finding in the nasopharyngeal carcinoma, and many times this syndromes or triad might be a question in the MCQ questions. We normally investigate nasopharyngeal carcinoma with CT scan and MRI scan to show the extension of the tumor. Neck ultrasound is the best tool to assess cervical nodal metastases, and biopsy normally confirms the diagnosis, and we will need a metastatic workup as chest CT scan, brain CT scan, bone scan, and abdominal ultrasound to assess the distant metastases. We normally treat nasopharyngeal carcinoma with either radiotherapy or chemoradiotherapy with a total dose of 5,000 to 7,000 rad over 5 to 7 weeks. For stage 1 and 2, we normally treat them with radiotherapy only. For stage 3 and 4, we treat them with concurrent cisplatin chemoradiation, and we use the cisplatin chemotherapy before starting the radiotherapy as what we call a radiosensitizer. So we sensitize the tumor tissue to the effect of the radiotherapy in such advanced cases. Next part of the lecture is the oropharyngeal tumor, which is broadly divided again into benign and malignant tumors. So benign tumor includes papilloma, which usually occur over the pillars or the uvula of the soft palate, or mixed salivary tumor, which arises in the glands of the mucous membrane of the soft palate. Malignant tumor includes squamous cell carcinoma, lymphoma, or sarcomas. Oropharyngeal carcinoma is the commonest malignant tumor of the oropharynx. It's common in male, common in elderly, and site of origin, it affects frequently the tonsil, and less frequently tongue base, and less frequently soft palate, and less frequently posterior oropharyngeal wall. Predisposing factor for oropharyngeal carcinoma is excessive tobacco smoking and alcohol intake. Oral human papillomavirus infection is another predisposing factor which has caused marked increase in the incidence of oropharyngeal carcinoma, especially in Western countries and United States of America. Spread of the disease normally has 3 methods of spread: direct spread, forward to the oral cavity, downward to the hypopharynx, upward to the nasopharynx, and laterally to the parapharyngeal space. Lymphatic spread is again early and common to the jugulo-digastric lymph node, and then to upper deep cervical lymph nodes, and distant metastases in advanced cases to the lung, bone, and brain. Many of these patients present clinically with a neck lump, which may be the earliest manifestation, sore throat, dysphagia or dynophagia, unilateral referred otalgia along Joseph-Hobson's nerve of the glossopharyngeal nerve. The signs: oropharyngeal examination will either reveal fungating mass or malignant ulcer, as you could see in the photos on the right side. Cervical examination might reveal bulky bilateral cervical lymph node, the common and maybe the earliest presentation, and again bilateral neck metastasis is one of the commonest presentation for oropharyngeal carcinoma, is the same as nasopharyngeal carcinoma as well, due to decussation of the lymphatics in the tongue base. We normally investigate oropharyngeal carcinoma with CT scan and MRI scan to show the extent of the tumor and to stage the cervical lymph node metastases. You could see in the top photo there is a combined affection of the primary tonsillar tumor and with a neck metastasis which is with a suspected extracapsular spread in the neck metastasis. Neck ultrasound is the best tool to stage cervical nodal metastasis. Biopsy will confirm the diagnosis, and metastatic workup we will need it to detect any distant mets. We normally treat oropharyngeal carcinoma with radiotherapy or transoral surgery with neck dissection for early stage disease. The transoral surgery is either transoral laser microsurgery or transoral robotic surgery. With the transoral laser, we use the laser to resect the tumor, while in transoral robotic surgery, we use the robot using the console of the robotic surgery, and we get the arms of the robot surgery, as you see in the photos, to cut and resect the tumor. The other way to treat this tumor is for advanced disease as stage 3 and stage 4. We normally use chemo radiotherapy for such cases. The last part of the lecture is the hypopharyngeal tumors. So hypopharyngeal tumor is the most common malignant tumor in the hypopharynx is the hypopharyngeal carcinoma, in which male are more affected than females, except in post-cricoid carcinoma, which is commonly affecting adult females compared to males. Regarding the age incidence, it's commonly affecting elderly people between 50 and 60 years old. However, post-cricoid carcinoma affects young females from 20 to 40 years. Sites of origin: hypopharyngeal carcinoma occurs more frequently in piriform sinus than posterior pharyngeal wall than post-cricoid region. And then predisposing factor is excessive tobacco smoking and alcohol intake. And the other predisposing factor is a Plummer-Vinson syndrome in post-cricoid carcinoma. And you could see in this diagram, here is the post-cricoid region, here is the piriform sinus on both sides, and from this point to this point is the posterior pharyngeal wall. So it's commonly affecting piriform sinus, then the posterior pharyngeal wall, and then the least incidence in the post-cricoid region. And I think there was only one study to document the incidence of the hypopharyngeal cancer in Egypt, and it revealed clearly that the post-cricoid is probably the most affected subunit in our country. The pathology of the hypopharyngeal carcinoma is that hypopharyngeal squamous cell carcinoma has the worst prognosis between all head and neck squamous cell carcinoma, with a 5-year survival less than 50%. So less than 50% of all patients affected with hypopharyngeal squamous cell carcinoma will die before 5 years. And this is largely due to that 80% of the tumors are low-grade tumors. These are moderately or poorly differentiated carcinomas. 60 to 65% of this patient present in advanced stage, either primary or nodal metastasis. And if you look at the diagram here, you could clearly see that T3 stage is the most common stage at the presentation, while N2 stage is the most common stage at the presentation. Patients are usually elderly patients with several comorbidities, and there is a pathological tendency for significant submucosal extension, more than 60% of the patient, which will make the surgical resection difficult and will make the radiotherapy and chemotherapy associated with higher incidence of recurrence compared to any other tumors. Clinical picture. So we have two main subtypes in Egypt. The most common one is the post-cricoid carcinoma, and the least common is the piriform sinus carcinoma. For post-cricoid carcinoma, patients normally present earlier with dysphagia, first to solids and then to fluids. Neck mass, mostly nodal metastases, is a common presentation due to rich lymphatic drainage in the hypopharynx. Hoarse voice and stridor due to either direct invasion of the larynx or recurrent laryngeal nerve infiltration. Unilateral referred otalgia along the Arnold nerve of the vagus nerve. Significant weight loss due to dysphagia and inadequate oral intake. Signs of post-cricoid carcinoma: neck examination will reveal unilateral, enlarged, stony hard neck mass, which is early mobile and later on might be fixed to the underlying structure. There is what's called Morse signs, means absent, normal, click, felt when the larynx is moved from one side to the other side over the vertebral column. So normally when we move the larynx in any normal person from one side to the other, we normally feel what we call a normal click. Absence of this click will means Morse sign, and this sign is absent in post-cricoid carcinoma, which means positive Morse sign. Hypopharyngeal examination might show the tumor either covered with frost behind the arytenoids, as in the top photo, so you can't see the tumor because the saliva, the frost, the pooling of saliva is blocking the view of the tumor, or we might get a view of the tumor while the patient makes an adduction during E maneuver of the larynx. Adduction of the vocal fold might bring up the appearance of the post-cricoid mass just behind the arytenoids. And for the piriform sinus or piriform fossa carcinoma, the symptoms in early stages are vague throat discomfort or neck lump. In later stages, they normally present with slowly progressive dysphagia, first to solids and then to fluids, hoarse voice due to laryngeal invasion, unilateral revealed otalgia along the Arnold nerve of the vagus nerve. And for the signs, they either present with neck for neck examination, they normally present with enlarged cervical lymph node, might be the earliest before dysphagia, as piriform fossa is one of the silent area of the laryngopharynx, and or hypopharyngeal examination will reveal either fungating mass or ulcerative lesion in one of the piriform fossae, mostly hidden by froth or saliva, as in the above photo, or you could clearly see the tumor if it is more advanced than the one in the top photo. Investigations for hypopharyngeal cancer includes barium swallow, will show either filling defect or obstruction. CT scan of the or MRI scan will show the extension of the tumor, as in the top photo you could see the tumor here eroding the arytenoid on the right side and eroding the posterior the posterior aspect of the thyroid lamina. So CT scan will show you the extension of the tumor, cartilage invasion, and any lymph node involvement if there is any. Neck ultrasound is the best tool to evaluate cervical nodal metastases, and rigid hypopharyngoscopy and biopsy will confirm your diagnosis. Metastatic workup is required to detect any distant myths. Treatment: we normally treat hypopharyngeal cancer with surgery followed by postoperative radiotherapy. Surgery might be either partial or total laryngopharyngectomy with neck dissection according to the extent of the disease. Pharyngeal reconstruction after resection is required, usually with either free flap, which is the most common one is radial forearm free flap or jejunal flap, pedicle demycutaneous flap as pectoralis major flap, gastric pull-up operation if the tumor is very extensive and extending downwards to the cervical esophagus. Then we need to remove the esophagus together with the pharynx and larynx, and then we normally do what we call a partial gastrectomy to make a gastric tube from the stomach, and then we try to mobilize the stomach from the abdomen up to the chest, and then we anastomose the upper end of the gastric tube to the lower end of the residual pharynx to create an anastomosis between the gastric tube and the pharynx and to restore the continuity of the digestive tract. And for the other patient, we might use either radiotherapy or chemoradiation according to the stage of the disease. Last part of our lecture is a cancer of unknown primary or occult primary. So cancer of unknown primary in the neck is the detection of metastatic cervical lymph node without an evident primary tumor. And this happens very commonly in silent areas of the head and neck, which are areas in which malignant tumor don't present with early local symptoms, but they are usually present with metastatic cervical lymph nodes. Common silent areas in the head and neck are tongue base, palatine tonsil, nasopharynx, piriform fossa, supraglottic larynx, and thyroid gland. For the management of such difficult cases, we normally take a history involving head and neck, chest, abdomen. We normally do a clinical examination as examination of cervical lymph nodes, examination of the other lymph nodes in the trunk and abdomen, thorough head and neck examination to detect any primary tumor. And in terms of investigation, we do CT scan of the neck, chest, and abdomen with contrast. We might need to do a neck ultrasound with fine needle aspiration cytology from any suspicious lymph nodes or from any suspicious thyroid lesions. And if this all fails to detect the primary tumor, then we will go for a PET CT scan, which an interesting and quite advanced staging scan in which we use glucose containing contrast, which will have very high uptake in the cancer tissue due to increased vascularity and increased metabolic activity. Will take a large part of this glucose contrast and will show up as a lightening in the scan, as you see in the down photo here. You can see there is uptake by the primary tumor and there is uptake in the neck metastasis. And this to detect the site of the unknown primary tumor. And this will be effective if the tumor is larger than 6 millimeter in size. But if it is less than 6 millimeter in size, it becomes difficult to be detected with PET scan. And then if all these methods fail, we need to do what we call a pan endoscopy, like endoscopy all over all head and neck areas, nasal endoscopy, nasopharynx, oropharynx, hypopharynx, and esophagus, and we need to do an endoscopy for the larynx and trachea as well, with bilateral tonsillectomy and with directed biopsies from any suspicious lesion if all imaging studies fail to detect any primary tumor. And if any of these finding came back with a positive finding for the primary tumors, this would be fine. This need to be treated. If not, we will treat the neck first and we will wait for the primary to show later on in life. Thank you very much for your attention, and I hope you all the best in your exams.